A meta-analysis pooling data from 30 randomized controlled trials found that progressive resistance exercise training significantly reduced circulating levels of C-reactive protein, interleukin-6, and tumor necrosis factor alpha in adults over 55. These are not abstract laboratory numbers. CRP, IL-6, and TNF-alpha are three of the most widely measured inflammatory markers in clinical medicine. Elevated levels of each have been independently associated in large prospective studies with higher risk of cardiovascular events, accelerated cognitive decline, loss of muscle mass, and all-cause mortality in older adults. If someone told you there was an intervention with that profile, studied in 30 controlled trials, you would want to know more about it. In this video, what CRP, IL-6, and TNF-alpha actually measure and why they matter specifically after 55, what the meta-analysis found in terms of effect sizes and what type of resistance training produced the largest reductions, the limitations you need to understand before drawing conclusions, and 3 practical takeaways you can discuss with your physician. Quick note before we continue, this is educational content based on published research, not medical advice. Talk to your physician before changing your regimen. Now, the study. To understand why inflammatory markers matter in this age group, it helps to know what chronic low-grade inflammation actually is. Unlike the acute inflammation you experience after a cut or infection, which is purposeful, targeted, and self-limiting, chronic low-grade inflammation is a persistent, diffuse, low-intensity activation of the immune system. It does not cause fever or obvious symptoms. It shows up as elevated circulating proteins and cytokines. By age 55, a measurable proportion of adults have baseline CRP levels above 3 mg per liter, a threshold that cardiovascular guidelines have historically flagged as elevated risk. This pattern of age-associated chronic inflammation has been given a specific name in the research literature, inflammaging, a portmanteau of inflammation and aging. We will return to this concept in the context of the full evidence picture later in this video. C-reactive protein is a protein produced by the liver in response to inflammatory cytokines, particularly IL-6. It is an acute phase reactant and one of the most commonly measured inflammatory biomarkers in clinical practice. High-sensitivity CRP, or hsCRP, is the version used to detect low-level chronic inflammation rather than acute infection. Levels below 1 mg per liter are considered low risk. 1 to 3 mg per liter is intermediate. Above 3 mg per liter is high risk. Interleukin-6 is a cytokine produced by multiple cell types including adipose tissue, macrophages, and skeletal muscle. It drives CRP production by the liver and also acts directly on immune cells, muscle, and the brain. Tumor necrosis factor alpha is another pro-inflammatory cytokine that plays a key role in muscle protein breakdown, insulin resistance, and endothelial dysfunction. All three operate within the same inflammatory signaling network. The paper we are examining conducted a systematic review and meta-analysis of randomized controlled trials testing resistance training in older adults, with inflammatory biomarkers as outcomes. The inclusion criteria required participants to be over 55 years of age, the intervention to be progressive resistance training, and the outcomes to include at minimum 1 of CRP, IL-6, or TNF-alpha. After screening the literature, the authors identified 30 eligible trials. Combined, these trials enrolled several hundred participants across varied populations including community-dwelling older adults with type 2 diabetes, adults with sarcopenia, and otherwise healthy elderly individuals. The training protocols varied considerably across trials in terms of frequency, intensity, exercise selection, and duration, which is both a strength in terms of generalizability and a limitation in terms of precise dosing conclusions. The meta-analytic method used was a random effects model, appropriate given the expected heterogeneity across trials. Effect sizes were calculated as standardized mean differences and weighted mean differences depending on the outcome measure. The primary outcomes were change in circulating CRP, IL-6, and TNF-alpha following the resistance training intervention compared to control. Blinding of participants is impossible in exercise trials, which is a structural limitation of all exercise intervention research. However, the outcomes here, blood biomarkers, are objective laboratory measurements and therefore not subject to reporting bias by participants. Here are the results. Across the pooled trials, resistance training was associated with a statistically significant reduction in C-reactive protein. The weighted mean difference was approximately negative 0.54 mg per liter. While this may sound modest in absolute terms, it represents a clinically meaningful shift within the risk stratification framework used in cardiovascular medicine. For adults starting above 3 mg per liter, a half milligram reduction can move them from the high risk to the intermediate risk category. Interleukin-6 also decreased significantly with resistance training, with the reduction reaching statistical significance in the pooled analysis. TNF-alpha showed a reduction trend across trials, with the effect being statistically significant in the subset of trials that measured it. When the researchers examined the training variables that modulated the inflammatory response, the picture became more detailed. Longer interventions, those lasting 12 weeks or more, produced larger reductions than shorter programs. Higher training frequency, specifically 3 sessions per week compared to 2, was associated with greater CRP reduction. Higher intensities, defined as 60% or more of 1 repetition maximum, tended to produce larger effects than lower intensity protocols. The combination of free weights and machines appeared to produce broader effects than machine-only training. These are patterns from aggregate data across 30 trials, not prescriptions. They point toward mechanisms and suggest variables worth discussing with a professional who can evaluate your individual situation. Now for the critical analysis. This is a meta-analysis of randomized controlled trials, which places it near the top of the evidence hierarchy for exercise research. However, several limitations deserve attention. First, heterogeneity. The 30 trials used substantially different protocols, populations, and measurement methods. A high I-squared statistic in the pooled analysis for some outcomes reflects this heterogeneity, meaning the effect estimate is an average across meaningfully different situations. The true effect in any individual depends on factors these aggregate estimates cannot predict. Second, most trials in this category are relatively short, typically 8 to 24 weeks. Whether resistance training produces sustained long-term reductions in inflammatory markers with continued training is biologically plausible but less rigorously established over timescales of years. Third, the study populations in many trials are not always representative of the full range of adults over 55. Some trials enrolled specifically health-compromised populations, others enrolled healthy volunteers. The applicability to any specific individual depends on how well their situation matches the studied populations. Fourth, exercise trials cannot be blinded for participants or exercise trainers, introducing the possibility that people in intervention groups change other health behaviors alongside the exercise protocol. Some trials attempted to control for dietary intake changes, but this is difficult to achieve perfectly over months of observation. These are not reasons to dismiss the findings but reasons to interpret the effect sizes as approximate rather than precise. 3 takeaways from this evidence. First, if your physician has flagged elevated hsCRP and you are currently sedentary, resistance training is one of the few non-pharmacological interventions with 30 trial-level evidence for reducing it. This is worth raising explicitly in your next clinical appointment, not as a replacement for any prescribed treatment, but as a documented adjunct. The conversation to have is, given my current CRP level and overall health picture, what resistance training protocol would you consider appropriate for me to start? That framing puts the clinical context where it belongs, with your physician, while informing you of the relevant evidence. Second, the evidence points toward frequency and duration mattering more than any single session intensity. 3 sessions per week over 12 or more weeks appears to produce larger reductions than 2 sessions per week over 8 weeks, based on aggregate patterns across the reviewed trials. If you are already doing resistance training, examining whether you have been consistent over a sufficiently long time horizon is worth asking. Inflammatory biomarkers respond to sustained training stimuli, not occasional intense efforts. This is a long-gain variable, not an acute response. Third, CRP, IL-6, and TNF-alpha are measurable. If you have a physician who runs a comprehensive metabolic or cardiovascular panel, asking to include hsCRP as a baseline measurement before starting a new exercise program creates a benchmark. Then, after 12 to 24 weeks of consistent resistance training, a follow-up measurement gives you objective data on whether your personal inflammatory response has shifted. This kind of individual tracking is not standard care, but it is scientifically reasonable and aligns with the approach of treating your own health data as useful feedback rather than abstract numbers. To summarize, a meta-analysis of 30 randomized controlled trials found that resistance exercise training significantly reduced CRP, IL-6, and TNF-alpha in adults over 55. The effect on CRP was approximately negative 0.54 mg per liter. Longer programs, higher frequencies, and moderate to high intensities appeared to produce larger effects. These findings are consistent with the broader inflammaging literature, which we cover in more depth in a separate video on this channel. This is educational content, not medical advice. Always consult your physician before changing your exercise regimen. Studies are preliminary, individual responses vary. If you found this useful, our free guide, How to Read Your Biomarker Panel at 55+, includes a section on inflammatory markers. Link is in the description. New evidence reviews publish every Tuesday and Friday.